everyone. I am Finza Latif. I'm a new attending psychiatrist at Sidra in Qatar, and I'm going to be talking to you guys about pediatric depression. Good morning to most of you, and probably night just in one place. So I have no real disclosures. I am going to be talking about some treatments that are not currently FDA approved in children, and I'll mention that. So I'm basically going to focus on four main areas, mainly the latest psychosocial and pharmacological treatment recommendations for pediatric depression. Also, my background is consult liaison psychiatry. I'm going to, as I talk about depression, also mention specific factors in medically ill children that are depressed. We'll also learn about suicide risk assessment and what tools can be used effectively in children and adolescents. And then if we have time, we'll talk about neurobiological markers. And then I have a couple of cases that we'll go through. So pay attention because the questions and the cases will be related to this talk. So we all know depression is a worldwide problem. And in global burden of disease, it's actually number 3, right behind diarrheal diseases and respiratory infections. In children, the main morbidity from depression comes from ineffective family relationships, school problems, inability to make or keep friends, getting into trouble at school with teachers, academic decline, and it also has implications into adulthood because childhood depression has actually been connected to lower quality of life in adulthood, as well as lower financial status and social difficulties. It is very much a disorder of youth because most adults will recall having their first episode of depression as an adolescent. The onset is usually at puberty. In fact, the prevalence of depression in females doubles at puberty. And all of these factors really highlight for us the importance as child and adolescent psychiatrists or clinicians that work with children and adolescents to keep screening for depression in mind, and early treatment can really impact adult outcomes. Mortality in depression comes from suicide, of course, and we'll talk about that separately. I'll mention some US statistics. The prevalence in the US in prepubertal children for depression is 2%, and much higher in adolescents at 9%, and it gradually increases through the lifespan up until 18-year-olds, where the prevalence lifetime is about 20%. About 5 to 10% children actually have subsyndromal symptoms that may develop into full depression and may still cause slight impairment. The age of onset, as I mentioned, is in early adolescents, 11 to 14-year-olds, and then a steady increase is seen. It's sort of a visual of the prevalence. Females being much higher than males, age ranges 15 to 17, we're seeing an increase here. And in the US, the certain ethnic backgrounds tend to have higher rates, and that includes Native Americans. Treatment rates, the news is not good for adolescents, and I think it's similar to adults in psychiatric illness. A large number of patients do not seek treatment or don't come to light. A small percentage are on medication only, 17% see a therapist as well, and then about 20% just see a therapist. There are some unique features of major depressive disorder in pediatrics which differentiates it from how it presents in adults. The major thing to remember is that a lot of times a child comes into your clinic with parents reporting angry outbursts, just irritability, low frustration tolerance, mood lability, which, as you know, in pediatric psychiatry, irritability is like fever. It could be stemming from depressive disorders, anxiety disorders, ADHD, So you have to then dig deeper to assess other symptoms that might be consistent with depression. Another thing that occurs commonly in children is somatic complaints. So they may not verbalize feeling sad, but they might complain of stomach aches, headaches, often before school. Hopelessness and anhedonia, which are key features of depression in adults, are less common. However, they are very much present in children. In fact, when I talk about neurobiological markers, anhedonia in children actually differentiates their brain functioning from patients or children without depression. A little bit about depression in medically ill children. Treatment of depression in medically ill children really requires an understanding of unique medical and psychiatric needs. Have to be flexible based on their evolving medical course. There might be adjustments in their medical treatment, and they may respond differently to therapeutic or pharmacological interventions, for example. Also important not to over-identify symptoms of depression in emotionally healthy youth that might be having normal negative reactions to the medical illness. However, if you see vegetative symptoms like poor sleep, poor appetite, hopelessness, and guilt, again, or anhedonia, then you want to specifically assess for either subsyndromal depression or major depressive disorder. Specific risks for depression that are specific to medically ill children. First of all, there are biological factors. So as we know, there are certain medications that directly impact either the inflammatory system or our depression pathways to cause. I've seen patients on the consult service with autoimmune disease on immune modulators who start having depressive symptoms as the medication is started, and then it resolves when the medication is stopped. And so the timeline of starting and stopping something and onset of symptoms can be helpful. In anticonvulsants, levetiracetam or Keppra, which is a brand name in the US, is actually one of the most notorious anticonvulsants that can lead to mood lability in children, irritability, and also depressive symptoms. But it's very popular these days to control epilepsy in children. The depressive symptoms, of course, can be caused directly by medical illness. We all read about hypothyroidism in med school. Autoimmune encephalitis is a newer illness that has been recognized in the 2000s. And the issue with autoimmune encephalitis is that the primary presenting symptoms are purely psychiatric, and often may get confused with straightforward major depressive disorder or even psychotic illness like schizophrenia. The way to differentiate or raise your suspicion of autoimmune encephalitis is if you have any neurological symptoms like abnormal movements in the child, or you have a child with depressive symptoms or psychotic symptoms who suddenly develop seizures, then the suspicion for autoimmune encephalitis is high. And this is where your body is making antibodies against NMDA, or most commonly NMDA or GAD receptors, although there are other receptors that haven't been really recognized. And it's treated much differently than major depressive disorder. So you want to consider neurological workup in those cases. Of course, hypoactive delirium often mimics depression. A lot of times the consults I get for depression actually end up being hypoactive delirium, also treated. Other specific risks for depression, there are psychosocial risks. So family factors can be important. For example, parents, their parenting may change when their child develops a physical disease. They may either underreport the presence of depression because they're over-focused on the medical symptoms, or they may not recognize the changes in mood. There are strong emotions about the child's illness. The parents might have additional responsibilities around other siblings, and so the parents themselves are at risk for depression or anxiety, which then impacts the child further. youth factors, of course, their quality of life is completely impaired when they have a chronic medical illness and require hospitalization. There are also certain developmental factors to keep in mind when you think about medically ill children and depression. Based on their developmental age, they will react differently and present depression in different ways. So in younger children, preschool age especially, as we talked about before, the most common symptom of depression might be tantrums. Often have a very limited understanding of what the medical illness is and may perceive it as a punishment to themselves. School-age kids can have a better understanding, and so they may worry more about what's happening to their bodies and present as chronic worry, while adolescents, we may see a more classic picture of anger and sadness as they have a more abstract understanding of the medical illness and what it implies. Depression in medically ill children can really present in three main ways. One, it could be an adjustment disorder adjusting to the medical illness, a straightforward primary depressive disorder, or the medical illness itself. So all this to say basically that it's very important to screen all medically ill youth for depression. There are certain screening tools that are available that could be used. The patient health questionnaire, there's a 9-question version and a 2-question version that is more appropriate for adolescents, while the childhood depression inventory, or CDI, which is available at a cost and it's not free, that can be used for younger children. It's important to use multiple sources. So talk to the parents if the child is in the hospital, talk to the nurses about their behavior, not just using self-reports in young children. And have a high index of suspicion. And if you see somatic complaints and maladaptive coping more than what you would expect, then you want to assess for depression. So going back to the mortality section, I made the suicide risk assessment sort of a separate section here. And we'll go through statistics and then assessment. Suicide is the second leading cause of death in adolescents aged 12 to 17 worldwide, and 90% of the youth who completed suicide did have a psychiatric. About half of them had a diagnosis of depression. So suicide is a separate phenomenon. It can occur outside of depression. Not always indicate a depressive disorder, suicidal thought. This is a graph of suicide rates in youth in the US from 75 to 2016. As we see, there was a rise in the 90s, antidepressants came about, there was a decline, but since 2007, in fact, there's been a steadily rising rate of suicide rates in the US. Because of these increasing suicide rates and rising rates of anxiety and depression, the Joint Commission, which is a hospital accreditation body in the US, sent out a Sentinel alert where they recommended that all hospitals should actually be using a validated tool to screen for depression, so not just asking questions about suicidal thinking, and then have a standardized method of assessment for suicide risk when you identify the patient who is at risk with, for example, active or passive suicidal thinking. So what is a validated tool for screening for depression that we can use in children and adolescents? There are a bunch of them, but I am highlighting the 3 most commonly used tools in children and adolescents. The first one here is the CSSRS, which is the Columbia Suicide Severity Rating Scale. It's a 6-question scale. However, if the first 2 questions are negative, which basically ask about suicidal thinking, then you jump to question 6, and so you don't have to ask all of them in negative risk patients. It just stratify the risk. It will tell you whether they're low, medium, or high. It can be used in kids ages 12 or above. The ASQ, or the ASK questionnaire, is a more recently developed questionnaire by the National Institute of Mental Health in the US. And this is a 4-question questionnaire. It was specifically developed for children and adolescents, and therefore it has much simpler language that's easier to understand and can be used in slightly younger children down to 10-year-olds. The PHQ-9, which I think a lot of people are familiar with, is actually a diagnostic questionnaire for depression. However, it does have one question on suicide. It can be used, again, in ages 12 or above. I just sort of, for you to look at, put up the CSSRS screening questionnaire. So you can see there's question 1 and 2 about thoughts of suicide, and then remaining about behaviors. So there were 2 steps to this. There's screening, where you identify kids that might have any thoughts, intent, or plan. And there is the assessment portion. A lot of us, do our assessment by doing the psychiatric interview and take into account past family social history and risk factors. However, this can still be pretty subjective. A high anxiety clinician, for example, or somebody without a lot of experience might overestimate the child's suicide risk, while somebody with a lot of experience might want to take some shortcuts and end up underestimating risk. So that is part of the reason why a standardized method of assessment is recommended for children and adolescents. And how assessment differs from screening is that assessment actually asks more about 3 things. 1, the intensity of the suicidal ideation. So asking about how long have the thoughts been going on? How often does the child experience them? Or do they feel like they can control the thoughts? Can they name any reasons that they won't act on these thoughts? And what are the reasons behind these thoughts? Is it in children and adolescents? Pretty commonly, in adolescents especially, it could be attention seeking, or whether it's actually to end their life. The second thing that needs to be assessed is the actual behavior. So if they attempted, was it interrupted? Was it self-interrupted? Was it interrupted by somebody else? What was the lethality of this attempt? Was it an adolescent who took 2 tablets of Tylenol, acetaminophen, because they were upset about something, or whether they took a large amount and needed medical interventions? And then risk and protective factors. This is an example of a standardized method of assessment. And basically, sorry about the small font, it basically asks the same questions that I just went over. And this is part of the CSSRS, but ASK questionnaire also has a similar available. Of course, I think, are all familiar with the risk factors for suicide. I just have these on here for you guys to look at. The number 1 factor in adolescence actually remains a past. And then it's also important in your assessment to look at whether protective factors are present. If the child is connected to the family, to the school, or connected to their providers in mental health, that can be protective. And having a fear of death, which a lot of adolescents don't have, but having that can be protective. When you think about implementing screening and assessment in a standardized way in a multidisciplinary setting, it can be very difficult and can be hard to do without specific guidelines. And one way to make these guidelines is using workflows and pathways. There are some that already exist that can be helpful. So the first one that I have up here is the Harvard workflow. So this is basically a workflow with embedded CSSRS questions. And then after asking the questions, it determines what their risk or what the next steps should be. So do they need an urgent full psychiatric assessment, which might lead to hospitalization or being to outpatient appointments, and also gives you the risk and protective factors. Similarly, there's a clinical pathway for suicide screening that was published through group through the American Academy of Child and Adolescent Psychiatry that actually provides sample workflows, which you would of course need to modify based on your different areas. So this is an example to be used in the emergency department. There are other workflows available for outpatient settings, etc. And again, this helps you, anyone that looks at it, whether it's a social worker who's doing the assessment, it can help them, it can help guide them. So now we're going to switch gears and talk about treatment updates. Start with psychosocial treatments. The evidence base on psychosocial treatments in youth is relatively new. In the 80s, the studies that were done mostly used adult measures and self-report only. In the early 90s, multiple reports, i.e. using parent and teacher reports, started and blinding was introduced. And then it was only in the late 90s that traditional clinical trials that we know of now and review or meta-analyses. This is basically the bottom line. This is based on a review that was recently published by Dr. Veer Singh in San Diego. They had very strict criteria into what studies they included, and they developed 5 levels of evidence based on the number of studies that showed statistically significant difference in depression symptoms in children and adolescents. And the 5 levels were well established, probably effective, possibly effective, experimental, and not effective. So not surprisingly, cognitive behavior therapy in adolescents was determined to be a well-established intervention, and both in its individual and group form. They also had enough studies on interpersonal therapy in adolescents to determine that that also fell in the well-established category. However, interestingly, cognitive behavior therapy in younger children was categorized as possibly effective because of the level of evidence that was available. And in fact, individual cognitive behavior therapy did much more poorly in children compared to adolescents and compared to group therapy or parent-mediated behavioral interventions in children. So those can be more effective in children compared to individual CBT. And IPT in children, it really has not been studied. We also looked at in these studies what predicts poor response to therapies. The predictors can be very helpful as general prognostic variables because they help identify who might benefit from an intervention and who might need additional target interventions to help. For example, morbid anxiety is a predictor of poor response in children and adolescents, and that might need specific interventions, CBT interventions for anxiety when you're treating these children. Also, high levels of suicidality, not surprisingly, and higher severity does not respond to cognitive behavior therapy alone, and we'll talk about that more when we talk about medications. Moderators are, similarly to predictors, can also help identify which patients may or may not respond and are helpful again in making clinical decisions about who should be provided the treatment. So the moderators in adolescents that may lead to poor response are a younger age, parental depression. So the parent might need to be in their own therapy before we'll see a response in children, and a history of trauma or comorbid substance abuse, which will each require a separate intervention. I don't really know much about moderators or response to IPT, but again, young age remains a risk factor, remains a moderator. on to pharmacological treatments. There's not a lot of latest news here, but I am going to go over some sentinel trials in children and adolescents for medications that I think all trainees need to be familiar with. These were all very large randomized controlled placebo trials done on children and adolescents that was funded by the National Institute of the US. There are three main ones. The TADS is a treatment of adolescent depression study. This was followed by the TORDIA, which is treatment of resistant depression in adolescents, and then a follow-up several years later, which is a soft TADS, which is a survey of outcomes that was done for these patients. So the first one that we'll go over is the treatment of adolescent depression. There were basically about 400 patients with major depressive disorder, and more than half of them had at least one comorbid diagnosis. However, serious suicidal thinking was excluded. So what they saw, there were four groups: fluoxetine alone group, a cognitive behavior therapy alone group, and a combination group, and then, of course, a placebo group. As we can see here, this is the response, not remission, but the response rate, i.e. improvement in symptoms at 12 weeks. The combination treatment did the best. It did separate from the other treatments, followed closely, and I think the percentage was about, 71% of the patients responded to combination treatment, followed closely by fluoxetine alone, about 61% of patients. CBT alone actually failed to separate from placebo in these adolescents, and these are patients above 12 in this study. And they looked at remission rates at both week 12 and then at week 36, or 3 months. Here, as we can see, combination treatment, the cognitive behavior therapy alone and fluoxetine alone, which had not shown a great response at 12 weeks, at 36 weeks actually caught up to combination treatment, and neither of these treatments were significantly different from the other, although they separated from placebo. So basically, that is to say, for a quick response, you want to use combination treatment, but eventually, if, for example, CBT is not available, fluoxetine alone could help the adolescent, but may take a few more weeks. Further at the results here, what we learned about CBT alone is that initially it could produce a robust response, but then failed to separate from placebo at 12 weeks. So CBT actually might be more successful for adolescents with mild depression or moderate depression rather than severe depression, which was the patient population. And that it may not be as effective for youth with significant comorbidities, because more than 50% of these kids had comorbidities. They also looked at another factor, and they saw that patients whose parents were depressed also responded poorly to CBT alone. However, CBT did have a benefit in safety. So the combination group had a lower rate of self-harm related incidents, 8% versus 11% for the fluoxetine alone group. That's what when we specifically look at suicidality in this study, all four treatment groups did show improvement in suicidal thinking, from 30% patients having suicidal thinking at start, dropping to about 10%. However, the rates of suicidal behavior were higher in the fluoxetine alone group, which is consistent with the warning that it comes along with use of SSRIs in children and adolescents specifically. There was no relationship in between suicidal thinking and time after starting an SSRI. The next study that they did is the treatment for resistant depression. So basically, they took about 100 patients who had not responded. that was another point that I wanted to highlight. When we looked at remission rates, I'll go back to the slide. Only about 60% of patients remitted at week 36. And so we know about 40% of patients did not actually remit. And these were the ones with determined to have treatment-resistant depression. When they looked at this group who had failed, this was specifically for the fluoxetine group. They took the patients that had failed the initial SSRI, i.e. and divided them into 4 different groups. They either switched them to another SSRI, in which case they used citalopram, or they switched to citalopram and added CBT, or they switched to an SNRI, a serotonin norepinephrine reuptake inhibitor, in this case venlafaxine, or switched to an SNRI and added CBT. And the results here showed that whether you switch to another SSRI or switch to another SNRI, if you added CBT, here the response was much greater. So in this case, we're seeing that patients who are resistant to SSRI alone may benefit a whole lot more to CBT than what we had seen previously. So if you have more comorbid diagnosis, you may have better response to addition. And again, this is combination. So better response to combination rather than CBT alone. And suicidality, both suicidal and non-suicidal injury, not surprisingly, was more in the drug group compared to the placebo group. And so that remains a risk factor when we treat kids. That was a survey that was done a few years after the intervention. Interestingly, they found that most adolescents actually recovered in average about 2 years. So everybody remitted, about 90, I think 5% was the number, in about 2 years, no matter what treatment they had received. This tells us a lot about the natural course of depression in adolescents. And additionally, about half of those patients, however, had a relapse at about 5 years. And again, the recurrence was not moderated by the type of active treatment. That means it didn't matter whether you were in the CBT group or the medication group, there was half of the patients will have relapse no matter what treatment they get for depression. Not great news, but as usual, that's not surprising for us psychiatrists as far as treatments are concerned. Again, we'll look at predictors of response. This is flipped so that these are positive predictors of response. And negative predictors. There's like hopelessness and neurovegetative symptoms. Young children, the news is even worse than for example, there was a study done on escitalopram, which is a metabolite of citalopram, where it was done first in 312 to 17-year-olds, where they showed similar response rates to fluoxetine. Study, about 60% of patients responded. However, very close to placebo response, about 54% of placebo patients responded. However, when they repeated this study in 6 to 12-year-olds, much younger children, looking at the time here, they actually did not separate at all from placebo. Similarly, there was another study done on SNRI, just duloxetine, where they looked at response to duloxetine, but also compared it to fluoxetine. In this study, they included younger kids, so 7 to 17-year-olds. And the study actually failed to differentiate duloxetine for depression, even though it's actually approved for generalized anxiety disorder in adolescents. It failed to separate for major depressive disorder at 10 weeks. But both the studies also failed to separate fluoxetine from placebo, which is very different from the adolescent study that we saw. So again, it's possible that addition of children in the study led to this failure to separate. So basically, the bottom line is that children have very poor response to the treatments that we have available. Back to looking at suicide, there was a treatment of adolescent suicide attempters, or the TASA study, which was also a sentinel study. And the main outcome from that study is what they saw, that suicide reattempters, so if you're an adolescent and you're going to reattempt, you are much, much more likely to reattempt within 4 weeks of your first attempt. These were more chronically sick children, of course. So the key take home from this is that if you have a child or adolescent, especially who comes in after a suicide attempt, intensive therapeutic contact early after the attempt is helpful. And this justifies acute hospitalization following a suicide attempt, and following discharge from an inpatient, really close follow-up, careful safety planning, developing coping strategies that the family is involved in, addressing likely precipitants that you might foresee in the home, either family conflict or school difficulties, right away to prevent that second attempt, which might end up being lethal. I'm just going to spend a little bit of time on new or rapid acting antidepressants that were just approved in the US for adults with depression, with major depressive disorder. They are not approved for children, but the reason I included these compared to others is that they are being used in children for other indications. So, for example, the main one that was just approved for adults is inhaled ketamine. You know, ketamine is an agent used in anesthesia for a very long time. It has been used in children for pain by anesthesiologists. Inhaled ketamine was approved by the Federal Drug Administration in the US that controls medications. It is an interesting administration schedule because of its high risk of abuse and the fact that it can cause intoxication as well as dissociative symptoms. You cannot take it home with you. You have to come into the psychiatrist's office twice a week to get your dose of inhaled ketamine for a period of 6 weeks. And of course, it's very expensive. It's about $600 a session. However, for patients with treatment-resistant depression, it might be something that can be helpful to them. The main problem is that it is the effect is short-acting. So you may have to, none of the FDA studies were really long-term to determine how long the remission lasts. Just something to know about. Additionally, the second thing that is somewhat new for treatment of depression, at least, are cannabinoid oils. So we know these have been around forever. Cannabinoid oils are basically oil from either the marijuana, the cannabis plant, or the hemp plant, which is it is the cannabinoid portion without the tetrahydrocannabinol, which is what causes the intoxication effect in marijuana. So the THC content in cannabinoid oil, or CBD oil as it's used for in short, is very low. From the hemp plant, it's less than 0.3%. From the cannabis plant, it's a little more than 0.3%. This This has become increasingly popular lately for all sorts of ailments, including anxiety, depression, pain, and it's available in various forms in tabs, oils, topical creams, even gummies. And it's available readily in the stores and you don't need a prescription. It is definitely not regulated by anybody and specifically for depression. However, in children, CBD oil was just approved for specific types. There are 2 specific types of epilepsy, Lennox-Gastaut and Dravet syndrome, and it was approved in children. So at least we were getting a lot of requests from patients and parents who were not responding to regular treatments of depression about CBD oil, but we really don't have a lot of information in depression. Even in Doha, I heard we had an adolescent who had imported a CBD oil from elsewhere and was using it. So it's so important to think about and ask about that when you have patients with depression. The main issue with CBD oil is that that it's not been studied, but there have been reports of side effects when used in children for epilepsy of elevated hepatic enzymes and respiratory depression. So it's not harmless, although a lot of parents and patients may think it's harmless. And also, there have recently been 3 or 4 deaths reported in adolescents who were smoking CBD oil for whatever reason. And the thought is that it has less to do with the cannabinoid, but the oil that is used as a medium. However, the risk is there. Finally, neuromodulation strategies, the ones in green, none of these are approved or studied in children and adolescents, but are being used as these are approved in adults for depression, so the ones in green. However, the ones not in green are not approved in adults either, but are being used both for depression and for other things. The newest one that I have heard about is transcranial photobiomodulation, which is using light in specific wavelengths. So we all know about light therapy. This is actually red light that is used, and it is thought to modify your mitochondrial function and help with depression. Really quickly, before actually, I think I'm almost out of time because we need to have 15 minutes for questions. So maybe just a minute here, important things to think about for medically ill children. For asthma, SSRIs can actually directly target asthma symptoms and can be helpful. Congenital heart diseases and epilepsy and diabetes all have much higher incidences of depression and prevalence of depression in children and adolescents. And therefore, they should be always assessed, and SSRIs and SNRIs, again, can be safe to use. With the caveat that bupropion can lower seizure risk and should be avoided. Obesity and IBD or inflammatory bowel disease, both, again, higher risks of depression in adolescents and lead to social issues. Cancer, of course, it impacts not just the patient, but the families. And here, psychoeducation, cognitive behavior therapy, relaxation strategies are often help enough for resilient families or patients. But SSRIs, depressive symptoms are present. And again, there can be symptoms that overlap, so it can be hard to differentiate. Presence of anhedonia or hopelessness should be warning signs. General guidelines for kids: start low, go slow, avoid polypharmacy, avoid benzodiazepines, monitor drug-drug interactions. If there are other drugs, look for herbals or dietary supplements, and reassess more frequently than adults. We'll skip neurobiology here because now I think we just have time for questions, and maybe I'll go through this case and we can open up discussion and any questions that people might have. So this first case is a parent bringing in a 7-year-old daughter because she's been having angry outbursts at home that started about 3 months ago and have gradually become more frequent. Mother states that these are triggered if she's reprimanded for getting a bad grade at school, which has been happening more lately. Previously, she was a good student. During these outbursts, she yells, screams, and cries, and often comments that she hates herself and wishes she was dead. Mother states that she herself, mom, is very frustrated and tired. When you interview the child, however, she denies feeling sad or hopeless. She expresses interest in an upcoming play date, really doesn't give you any depressive symptoms. What other questions would you want to ask? Maybe we can. You can feel free to text me your answers or questions. So I'm hearing no answers or questions at this point.
Because she wishes that she was dead, मगर हमने पूछना चाहिए further किसके साथ करते हैं किस Mike Dazzle. Start with first, na interview.
Text my sister. My sister.
Unfortunately, I can hear a lot of people talking, but I can't really understand what's being said. So, but hopefully it's generating a good discussion amongst yourselves. And basically you want to ask, definitely you want to ask the parent more about any stressors or trauma that might have happened 3 months ago for this child, and then going through the depressive symptoms with the mother, because she may have observed these while the child herself may not be able to verbalize the symptoms. And of course, you also want, there's academic decline, you also want to ask about attention and concentration at school and what might be going on at school. So the differential diagnosis could include anything from major depressive disorder to possibly ADHD, because untreated ADHD can lead to depressive symptoms. Secondarily, however, because again, this is not characteristic of the child, this is much more likely to be a new onset mood disorder. Second case is a 14-year-old boy in clinic who presents with both his parents. Parents state that they've been worried because their son spends all his time in his room and has stopped seeing his friends. He has always been an introvert, but he has again been more isolated over the past 6 months. He used to play football, but now refuses to go. He's missed a lot of school days because he does not get up on time. You speak to the patient alone. He states he feels life doesn't matter. He feels school is useless. He does not feel he can be successful at anything. He states that he's been late to school because he cannot fall asleep at night, so he sleeps in the morning. He finds no pleasure in playing football as he did before. He states he has lately wondered if it may be better for him to jump off a bridge. So what questions would you ask to further assess suicidality?
Whether he's actually gone there in person. Whether there actually has been an
suicidal thinking itself, like when did these thoughts start? How often does he have them? Can he control them? What are the reasons? Which, that part is clear. His mood is low. And then whether there's been an attempt, what was the attempt like? How lethal was it? And then assessing other risk and protective factors. What else is going on? Is there a family history of depression, family history of suicide attempts? This is pretty clear that that's, straightforward major depressive disorder. However, in adolescents, often sleep issues can present on their own. They might have sleep advance where they're not sleeping at night and then sleeping during the day, and that causes problems with school. So sleep is important to address in adolescents. So you complete a depression inventory and you get a moderate to severe level of depression. What treatment modality would you want to use in this patient? Yes, an SSRI in addition to therapy, because as we looked at earlier, therapy alone for moderate to severe depression in the short term is not that helpful. And for an adolescent, 3 months is a very long time, or waiting 2 years for self-resolution also is a very long time, because it will lead to social and academic decline, as we're seeing already. So that's one way of explaining to parents who might be hesitant to start medication on a boy who they just, for them, this is all new and they might want to try therapy alone. It might be important to talk to them about the evidence that there is a possibility 60% of patients will get better much faster if a combination treatment is used for severe depression where suicidal thoughts are present. All right, great. Any questions that I can answer? I have about 7 minutes. Anything that I didn't mention? I can't hear, so if you guys want to maybe type a question, that would be helpful.
Disconnected.
Okay, I can hear somebody.
Hello, I'm Dr. Vasudev. Can you hear me?
Yes, I can hear you.
I'm from Doha University of Health Sciences. Brilliant talk, I must appreciate. I have a question. You discussed about cannabis oil in children.
Yes.
I mean, there are many shops, cannabis shops. You discussed that tetrahydrocannabinol is less than 0.3%. So what are the beneficial ingredients in that? Is it only cannabidol or others also, and what's the benefit and risk ratio?
Yeah, so there are 2 types. So yes, many shops are selling it. There are 2 types. One type, the THC ratio is less than 0.3, and another type where it can be more than 0.3. The benefits, as I said, have been found in, again, children with 2 types of epilepsy. It actually, which is resistant to other types of anticonvulsants. It has also been found to be effective in pain because it works on your cannabinoid receptors. So similar to marijuana, it can help with pain without the intoxication effect. And lots of people have self-reported improvement in mood and anxiety, but again, this has not been studied in a standardized fashion. Did that answer your question, or did you have a specific thought in mind?
I mean, what are the beneficial ingredients other than cannabidol?
Oh, other than CBD? what other oils are available? Is that what you're asking?
Metabolites of cannabinoids, means which are really helpful in uplifting depression.
No, I actually am not familiar with other metabolites other than the CBD oil. Are there others that you know of that are available?
Thank you.
All right. Thank you so much, everyone. I would really appreciate, Danielle is going to send you guys a feedback form. If you could fill that out later when you have time and email back, that would be very, very helpful.
All right.
Very,
Dr. Finza, thanks everyone.
all right. Bye. Have a good day.
Thanks.
Wonderful presentation, and we have learned a lot.
Thank you. Thank you. That's lovely to hear. All right. Back to patients.
Good office.
Good office.